Good morning. Thank you so much for joining us. My name's Tim Poe. I'm Director of Telehealth with the UNC Lineberger Cancer Network. We'll be starting our lecture right at noon today. So thank you for being a few minutes early. While you're waiting, I want to let you know that if you're experiencing any technical difficulties at all, please let us know. You can call us 919-445-1000. You may email us unclcn@unc.edu. Good news is that this lecture today is being recorded. In about 1 month, it will be available as an enduring material that can also be taken for credit. Otherwise, we hope that everything's working, but let us know if you're experiencing any problems. While you're waiting, you might want to visit our website, and our primary website for the purposes of this lecture and the other lectures is our learning portal, and that's learn.unclcn.org. You can also visit our main site, which is unclcn.org. So either way, but learn.unclcn.org is a good place to look at some of our upcoming lectures. And also you can see all of the lectures that are in our self-paced online courses or SPOCs, those enduring materials that you can take on your own schedule. All right, we'll go ahead and get quiet for a couple of minutes. We'll start right at noon. See you then. Right, and we are going to go ahead and get started. Good afternoon. My name's Tim Poe. I'm Director of Telehealth with the UNC Lineberger Cancer Network, and I want to welcome you to this patient-centered care lecture today, July 9th, 2025. If you are having any technical difficulties, you can give us a call, 919-445-1000. You may also email us, unclcn@unc.edu. We do have people standing by to help. I want to go through just a few things and then meet our presenter and get started. We will be using Poll Everywhere today. This is a great way for you to respond to questions that Danielle will be asking in real time. You'll go ahead and use the app. You can share your answers. It's all anonymous. We're not grading you for this, so make your best guess on those answers, and then she'll let you know how you did on those. And the way this works, you go to pollev, POLLEV.com. You enter the letters UNCLCN, that's UNCLCN, and then you'll see each question come up. Pick the response that seems most appropriate. At the end, and we'll let you know when we're close, you can go ahead and start sharing your questions. I suggest jotting those down somewhere as we go along and then going ahead and typing those in. And you can do this on that pollev.com. That can be done on any laptop, any smartphone, any tablet, any connected device. So just go to any browser to do that and should be all set. I know that many of you will be wanting to claim credit, and that's available at no cost. To do that, you do need to attend at least 53 minutes today. And the whole experience with Zoom with the slides and the video and the audio. At the end, you'll go ahead and you'll fill out an evaluation, and then you'll claim your certificate, and you do need to do that within 7 days of today. And feel free to reach out to us with any questions. The way this works, we go ahead and do this in Zoom. At the end of Zoom, we send the attendance data over to our learning portal, and then we can let you know if you're eligible to claim credit. If for some reason you had to leave early or got here late, we do have that enduring material, the SPOC option as well. All right, this is one of multiple series. So we also have our Research to Practice series, our Advanced Practice Provider series, and then in partnership with Duke and Wake Forest, our Southeastern American Indian Cancer Health Equity Partnership, also called SICEP. Encourage you to go to learn.unclcn.org and check out all of those different courses, past, present, and future. Always appreciate it if you can help spread the word about these lectures to colleagues who you think may have an interest in these and the varying types of continuing education credit available at no cost. If you would like to get flyers and emails that are easy to share out with your colleagues, just go to unclcn.org/promoter. Always great if you can follow us on Facebook, Insta, LinkedIn, and we post things there as well. And so patient-centered care, from barriers to bridges, addressing social determinants of health in cancer care. Danielle Julian, BSN RN. Danielle, welcome. So glad to have you here today.
Thank you, Tim. Happy to be here.
So we've got a full bio. We're not going to read that. We'll let folks go back and read that if they want to, but we've got some key things that we wanted our audience to know about you. You once launched a cancer supportive care podcast at Stanford during the COVID-19 pandemic, and were inspired to become a nurse after a meaningful conversation with a World War II veteran, and grew up raising sheep in 4-H and still dreams of having a farm full of animals one day. Travel is your joy and the reason you bring cultural curiosity and deep listening into every conversation, and never planned to go into oncology nursing, but fate had other plans and now you can't imagine anything else. Is that pretty accurate?
That's pretty accurate, Tim. Yes.
And what's one other thing we should know about you outside of these items?
I have 2 kids, expecting a third, and my kids are everything to me. So when people ask what are my hobbies, it's whatever my kids want to do. I'm definitely very big with my kids and my family.
That is great. Thank you so much. So Poll Everywhere we mentioned, and the first question is, what is an example of a social determinant of health? And I see some folks are already answering that, which is perfect. A is education access. B is healthcare access. C is economic stability. D is neighborhood and build environment. E is social and community context. And F is all of the above. So let's give our audience about 10 more seconds. Already have nearly 100 people here. That's outstanding. Danielle, how are they doing?
I think they're doing really well. Those who have selected F, all of the above, they would be right. And we'll dive into a little bit more of what are social determinants of health. But for everybody that selected all of the above, you are correct.
Terrific. All right. Well, thanks to our audience for jumping in and responding to that first question. And from barriers to bridges, addressing social determinants of health and oncology care. Danielle, take it away.
All right. Thank you, everyone, for being here today. So I'll go over the objectives for today's presentation. So we're going to work on identifying common social determinants of health affecting oncology patients, describe the impact of these determinants on cancer care outcomes, and use practical strategies to address social barriers and promote more equitable oncology care. As Tim said in the beginning here, I never planned on going into oncology. It was kind of written in the stars, and this is something that is very near and dear to my heart. I have been all across the United States in various medical academic settings, and have really kind of learned a little bit more in the different areas where I've lived, how social determinants of health really kind of impact oncology patients across the United States and forevermore across the world. So we'll start off with another question because I want to kind of dive into this a little bit. So Tim, go ahead.
Sure. So, what term describes the strengths, challenges, and barriers related to the health and well-being of people and our communities? And A would be social determinants of health, B, health-related social needs, C, social barriers, or D, all of the above. That's good. We're 50-50 moving around here. And you can change your mind if you think it over and say, maybe it's this instead of that. We've got about 10 more seconds. All right, so we've got about a third with A, about 2/3. Well, it's kind of fun. It's like a horse race here, seeing them move back and forth. What's the answer you were looking for, Danielle?
So this is a little bit of a trick question, but D kind of encompasses for the social determinants of health, health-related social needs, and social barriers. All of those terms kind of describe the strengths, challenges, and barriers related to health and well-being. So for this one, it is also all of the above, and we'll dive into that a little bit more, and I'll explain some of the key differences.
Great. Thanks so much.
All right. So what are social determinants of health? You can see this definition here from the CDC, but really think about social determinants of health as the non-medical factors that influence health outcomes and quality of life. So these encompass conditions where people are born, they live, they learn, they work, they age, and kind of as a broader system that shapes daily life. So as you can see here in this little picture, you have 5 key areas of the SDOH, or what SDOHs are. So you have education access and quality, healthcare access and quality, neighborhood and built environment, social and community context, and economic stability. So studies show that at any point in time, 68% of cancer patients report at least one social need or barrier, such as transportation, housing, or food insecurity. So that's 68% at any point in time. So it's, a lot of people think of social determinants of health of like, it's not just healthcare, it's not just accessing it, it's everything surrounding it. So you may also hear these terms: social barriers or risk, social drivers of health, and health-related social needs. So SDOH, think of that as the kind of umbrella term. They can be used interchangeably. but they are a little bit different. So social barriers and risk is really looking at the specific adverse challenges a person faces that increase their risk of poorer health outcomes. Social drivers of health is more of that action-oriented term that emphasizes the modifiable forces behind the SDOH. The health-related social needs is the more of the individual level social need that directly affects a person's health and kind of healthcare access and use. Oh, I think I went, hang on, let's see. There we go. Okay. So let's see. I think I skipped a poll everywhere question, Tim. Sorry.
Oh, no worries, no worries at all. So which of the following is an example of a social determinant of health? A, smoking, B, body mass index or BMI, C, access to safe housing, or D, tumor biology? All right, and this is great. Really appreciate our audience jumping right in and going ahead, making their best guess on these questions. Wait just a few more seconds. Seems like folks have kind of settled on access to safe housing. How are they doing?
They are right. Access to safe housing is one of the classic SDOH examples. The other choices are more health outcomes, not really social determinants.
All right, thank you.
Okay, so let's take a look at what the data tells us about cancer in our state, in North Carolina. So these graphics are pulled from the UNC Lineberger data dashboard. So right here, we're looking at the cancer incident rates from 2016 to 2020. As you can see, the statewide average is 464.4 per 100,000 residents, which is higher than the national average. So if you look at the dark navy blue counties, those are ones that have a higher than the national average for cancer incident rates. I want you to kind of keep a focus on this county here. This is Halifax. And then I want you to look over here. We've got Robinson County in this little area. We'll kind of dive into those in just a little bit. So this one is looking at the cancer mortality rates. So again, North Carolina unfortunately has a higher than the national average for cancer mortality rates as well at 154.4 per 100,000 residents. So kind of you can see also going from this slide here to this slide, you do see a lot of that overlap in those navy blue counties where they're above the national average. The next slide I'm going to show you is the social vulnerability index. So what this map is really showing is the overall social vulnerability, combining themes like socioeconomic status, household characteristics, or kind of who makes up your household, racial and ethnic minority status, household type, and transportation. So when we think of social vulnerability, we think of that it's not just income, it's all the other factors that kind of are included in this person's life. So we also know that high social vulnerability is often correlates and linked to delayed screening and later stage diagnosis. Now, this map that I'm going to show you looks a little bit different from these. I pulled this from the U.S. Census Bureau. It's from 2023, but this is showing the poverty rates in North Carolina. So the statewide average is about 12.8%. As you can see, the darker orange counties have higher poverty rates. I wanted you guys to kind of look at Robson County over here. It's at 27.7%. Poverty. Now, we do have about a dozen counties in the state of North Carolina that are ranked and kind of fall within the bucket of counties of persistent poverty. So that really kind of does a number for the North Carolinians that live here. Another thing that I wanted to point out from this, because I work primarily with UNC in Chapel Hill and Hillsborough, that sort of thing. So we look at, Wake, Orange, Durham counties, et cetera. They have a lower lower than the statewide average for poverty rates, but you're also kind of combining that into major metropolitan areas. The same thing can be said over in Mecklenburg County, as well as New Hanover towards the coast. So anywhere that you have more of a metro population, it's going to kind of skew the poverty rates a little bit down, but it isn't always the full picture. So that's really why we think about kind of the social vulnerability index. So when we think about cancer care, we often focus on these two sections here, diagnosis and treatment. But the journey actually starts a lot sooner and continues long after treatment ends. One thing I really wanted to highlight with this slide is that this is not linear. Sometimes there's a diagnosis, they go through treatment, they're in survivorship, but then something reoccurs and it's back to the beginning. Another thing to highlight, especially as it relates to social determinants of health, is this little screening dot or point in the journey. So we do know that in our rural populations, in our rural communities here in North Carolina, as well as elsewhere within the nation, that access to screening can be limited. And we may think of things like, okay, a simple screening mammogram, that could mean missed work. Who's going to take care of my kids while I get this appointment done, and then drive and transportation to get to that. So each of these kind of highlights all the different areas where these SDOHs and where these social barriers and risks come into play. And it can happen at any point and often at multiple points within the patient's journey. So this is a really busy slide. Hang with me. I wanted to break it down into some common barriers that our oncology patients may face. So I've kind of broken it down into 6 different arenas here. So the first is economic. So looking at income or job loss, looking at no insurance or insurance limitations, where you're able to go based on your insurance carrier. And medical debt and financial toxicity. So we know that in the state of North Carolina, we have 9.3% of our North Carolinians that are uninsured. When we think about like insurance payers, we've got like 18.5% that are on Medicaid, about 19 to 20% that are on Medicare. When we think about financial toxicity, that was coined in 2013 at Duke Cancer Institute. And that really describes the negative impact that medical expenses can have on a patient and their families. So North Carolina being a so North Carolina being a safety net hospital, we serve, as the state hospital for North Carolinians. And that's really important because if it wasn't for UNC and a lot of kind of the financial assistance programs that we have, many people would not be able to seek care. The next would be here healthcare access. So looking at transportation challenges. In many parts of rural North Carolina, transportation alone can be a defining health factor and a social barrier and risk for patients receiving care. Limited health system navigation support. I feel like we're very fortunate here at the medical center that we have a central navigation team and how wonderful that is to be embedded within the standard of care and for our patients to be able to really provide that one-on-one support. But that does not necessarily mean that happens at other kind of the smaller community hospitals or even out in the community outpatient oncology settings. As well as geographic disparities. So meaning with this, looking at sometimes it takes people a little bit longer or they have to drive a little bit further to get to more specialized oncology care. Housing and food. So we've got housing insecurity, food insecurity or food deserts, and compromised or unsafe housing. So wanted to highlight kind of food insecurity. A lot of people think food insecurity is just hunger. No, it's also the stress and uncertainty of not knowing where your next meal is going to come from. And I think that is really common and unfortunately not something that's talked about a lot because there's a lot of kind of guilt or shame related to like, I don't have enough food to eat, or I don't know where my next meal is going to come from. For the compromised or unsafe housing, North Carolina gets very scorching hot in the summer, and it can get really cold and snow and be really frigid in the winter times here. So just wanting you to think about, imagine finishing chemotherapy and you go home to a house without heat and what that does to our patients and how do we support them. For social context, looking at the lack of social support, there's also stigma, discrimination, and bias, and cultural or language barriers. So we know in the state of North Carolina, we have over 1 million Hispanic or Latino residents. And often lack of bilingual providers and interpreter services increases those healthcare and healthcare gaps and disparities. The neighborhood factors, rurality, so living in a rural setting. Most of North Carolina is still rural. Limited screening access and environmental exposures. And then for education and literacy, we have low health literacy, misinformation, and educational disparities. One thing I'd like to note with the low health literacy is as everything is moving to more of a digital platform, we're also noticing gaps and disparities with digital health literacy, people being able to access their MyChart to communicate with their doctor or get information about their appointments. It's becoming a bigger concern, especially in our oncology patients as they're trying to navigate many different appointments and providers for different treatment plans. So let's look at kind of who's most at risk. So let's look at the SDOH impacts on vulnerable populations. The first we have is older adults. So they're often managing multiple chronic conditions alongside their cancer. We often find that they may live alone or have limited social support. And then also with this older adult population, there's a potential of cognitive decline or physical frailty that can make navigating the system harder. For our racial and ethnic minorities, it's not lost on any of us that we know that Black and Hispanic patients face a higher cancer mortality rate, despite some overall incidence in some cancers. They're more likely to be diagnosed at later stages due to screening gaps and mistrust of the healthcare system. They're less likely to receive timely or guideline-based treatment like chemo or surgery as well. Our low-income patients, so I mentioned that about 9 to 10% of North Carolinians are uninsured. That also could mean underinsured. I think there's a big knowledge gap in what is considered underinsured, and that means even with health coverage, the co-pays, the deductibles, et cetera, are still kind of significant, and that can tie into especially people that have a lower kind of like a fixed income or lower income. So low-income patients are more likely to experience that financial toxicity. They often have lack of transportation or insurance or paid time off. That leads to delays in care, missed appointments, and they may also have limited kind of health literacy. Again, looking at patients that live in rural areas, so traveling long distances to see an oncology or specialty provider to get the imaging or the treatment that they need, relying on community hospitals without specialized care. I said again here that uninsured or underinsured, so delaying diagnosis due to cost or fear of medical bills. Unfortunately, that is a really common thing that we hear in our navigation program when our oncology patient navigators are talking to them of, now they're diagnosed with a later stage and it's like, hey, I didn't have the money to come in to get a screening appointment or to do, to get further workup. So they're facing those barriers as well. There's also evidence that shows that uninsured and underinsured have less access to palliative care and survivorship services. Survivorship services in general are a little bit low, and I think that we're still trying to optimize how we make those more available for a wider net of patients. And then the sixth category here that I have is the LGBTQ patient population. So a lot of patients within this kind of segment face discrimination or lack of provider cultural competence. As I said, like North Carolina is still pretty rural. We are making strides and changes and providing more education. So providers and clinicians feel more comfortable in kind of addressing the social needs of the LGBTQ population. But they're often less likely to be screened for especially gender-specific cancers. They also have a higher rate of mental health challenges and social isolation. So I always like to kind of bring it back to like a real life patient story. So Melvin's story is far too common in our state and very prominent of kind of what we experience as clinicians when we have a patient that comes in. So Melvin is 72 years old. He lives in a small town in Western North Carolina. He used to work on a tobacco farm and smoked for many years before quitting. When he started having a sore throat and trouble breathing, he put off going to the doctor because the nearest clinic was over an hour away and he didn't have a working vehicle. Eventually, Melvin was diagnosed with an advanced throat cancer. He was able to get his neighbor to drive him to his appointment. He doesn't fully comprehend his cancer and what to expect or any of his additional health needs. He needs things explained to him in simple terms or layman's terms, as we often hear from our patients. And he continues to struggle with affording food, nutritional supplements, and some of his medication. So if we take a look at some of Melvin's barriers just kind of laid out here, there's the issue of transportation. He doesn't have a working vehicle. It's a long way to get to the nearest specialty clinic, and coming from Western North Carolina, if he were to be seeking care here in the Triangle or getting a consultation here in the Triangle, that's an even longer travel distance. He's having concerns about money. You know, he's 72 years old. He's probably maybe on Medicare or underinsured. We hear a lot of Medicare patients talk about the donut hole. So once they reach a certain kind of threshold, then it's kind of, they don't know how to come up with the money that's needed for the additional medications. We also know that with advanced throat cancer, like nutritional supplements, things like Ensure, we have people stay on because it's so important for them to kind of keep up their nutritional status and caloric intake. But those can become really cost prohibitive. They're, 20 to $40 depending on the brand and how much you get. And that doesn't really last a whole long time. He doesn't really understand kind of what's going on. So again, we have this issue of health literacy, not really knowing what to ask, how to approach the team if he has questions. One thing that I have always found really interesting is when there are kind of lower health literacy, or maybe there's cultural or language barriers, you get a lot of patients that are just like, yep, okay, I understand. And then you go back and try and do a teach back, like, okay, what did you pull from this conversation? And they have a really hard time explaining that. So being able to meet Melvin where he's at and being able to explain things in layman's terms is so important. I also put on here the stigma related to his past tobacco use. Didn't really mention that in the story, but thinking about him, he smoked for many years. Now he's got throat cancer. We find that a lot of times in our head and neck patients, our thoracic patients, like, well, I kind of did this to myself. They're not really going to treat me very well because, I was a smoker for so long. And that may hold them off from seeking the appropriate care that they need. So, Tim, I'll have you chime in for this one.
Absolutely. So, which of the following is most likely to delay cancer treatment? And would that be A, difficulty understanding medical information, B, lack of transportation, C, inability to take time off work, or D, all of the above? Seems like we'll wait about 10 more seconds, but it looks to me like people are paying very close attention. How are they doing?
They're doing great. It is all of the above. So the difficulty understanding medical information ties into that health literacy, lack of transportation, one of those key SDOH domains, and then the inability to take time off of work, a huge one that we see, especially in our younger and working populations.
Great. And I just want to remind our audience to be jotting down those questions. And then a little later, we'll remind them in the chat that they can go ahead and start submitting those.
So kind of when we think back about Melvin's story, his journey didn't really start with biology. It started with barriers for the diagnosis and his treatment planning and all that. He had so many barriers, the rural location, the poverty or financial strain. It was kind of a stacked risk, right? So he might miss appointments, he might skip his meals, or he could even misunderstand instructions. So if you don't have a patient that really kind of understands what's going on with their care and what they need to be doing, that's a big one that we see as nurses, that they're misunderstanding what they need to be doing or how they need to be taking their medicine or when they need to be taking their medicine. So for Melvin, he doesn't really need sympathy. He needs solutions. So I wanted to kind of tie in, sorry, my screen went a little bit too fast here. So I wanted to try and tie in how the system is trying to respond. So connecting this to the value-based care and the enhanced oncology model. So with value-based care, including the EOM from CMS, the focus is to have better health, lower cost, and more coordinated care, more patient-centered cancer care. So Melvin's experience highlights a lot of the key gaps that a value-based model aims to address. How does a value-based care or EOM support this approach? So practices, clinicians must screen for SDOHs, including housing, food, transportation, and support systems. And I think that kind of falls on everybody within the care team. We have, our navigators that do that. It's also up to the clinicians and the clinical nurses that work in clinic. It's also up to pharmacy. I think we do see a big gap there of maybe they're good and don't have a whole lot of social barriers or kind of needs, and then they get to these really exorbitant cost medications, and that's where things can kind of dissolve. There is an emphasis on coordinated and timely care to reduce avoidable ER visits and hospital admissions. And then providers are encouraged to improve quality and equity, not just deliver treatment. So I know that's going to be a big kind of topic with UNC and kind of moving as more hospital systems are moving to a value-based care model. So when we think about this, value-based care pushes us to think bigger. So not just did Melvin get his treatment, did he get his chemo, but was it on time? Did he make it there? Was he supported at home? Value-based care gives us the tools and accountability to do that. I want to highlight this because it's very near and dear to my heart, is the critical role of navigation. Like I said, we're very fortunate here within the Triangle at UNC at Med Center to have a fabulous team of navigators, both as oncology patient navigators and volunteer navigators. And they do a plethora of things, but they work in conjunction, in unison. They work together with the social work team, with the clinical care nurses, with the providers, with the pharmacist. So kind of what is really important and kind of bringing navigation to the forefront is because they are SDOH experts. So they are able to do calls and do SDOH screenings, looking into early identification of transportation, housing, or financial barriers. We hate for patients to kind of get into the system and they're getting ready to start treatment, and then it's like, oh my gosh, they have all of these things going on, and how do we help them? Time is running out. We're trying to get them to treatment, appropriate timing of that. It's a big thing. Resource connection. So helping assessing gas vouchers or parking passes or temporary lodging or meal support. navigation in general, especially in the oncology population, has really started to grow over the past decade. And they leave no stone unturned. So it's really just trying to see what is the patient, what is kind of top of mind for them. So I'll give an example from one of our team. Like there have been OPNs that have helped patients get vet visits for their pets and their dog food, because that was what was kind of keeping the patient going. So again, when we look at SDOH, when we look at how do we care for the whole person, we have to meet them where they're at. So what may be kind of like a big glaring problem or issue or potential barrier, they may think of as like, hey, no, this is actually a little bit more important. So our OPNs and navigation across the state of North Carolina is really working to help with resource connection. Like I said, in conjunction with the care teams, in conjunction with the social work teams. Care coordination, so ensuring Melvin stayed on track with radiation and follow-up appointments. And then health literacy and emotional support. That's a big one. It's really kind of a humbling experience to work in oncology care, because you are working with people during some of the worst time of their life, and they really need that kind of clear explanation. They want to have a trust in their care team and building that rapport, addressing the stigma around mental health during cancer, and just, kind of building that patient up so they can get through their treatment and onto survivorship. I'll give another example here. So we're going to meet Mary. Mary is a 42-year-old Black woman who was diagnosed 3 months ago with stage 2 triple negative breast cancer. Her treatment plan includes weekly chemotherapy infusions, followed by potential surgery and radiation. Her oncologist recommended and emphasized the importance of her treatment adherence due to the aggressive nature of her cancer. She's a single mom of 2 kids, ages 10 and 8, living in Vance County. Mary is also the primary caregiver to her mother, who is also in cancer treatment. So with Mary's story, it really brings SDOHs into sharp focus, because it's looking at the realities of juggling both a cancer diagnosis, caregiving, and survival. Stage 2 triple negative is one of those fast growing and aggressive cancers. So timing is everything. Getting her to treatment is everything, but her treatment plan is really intense. She lives in Vance County. Vance County has about a 19% poverty rate, above the state average of about 12. It's also a rural area with pretty limited resources. So when we take a look at some of her barriers here, we've got the healthcare access and transportation. Can she get to her appointments reliably? She's not only juggling kind of her diagnosis and what's going on with her, but she's got 2 school-aged children. She also has a mother who's going through cancer treatment. So is she able to get to her appointments reliably? For childcare instability, who watches the kids when she's getting her chemo? Who's going to help out with the kids when she potentially has to have surgery and needs to take a little bit of time off with that? The mental health strain, so burnout from both being and also her own illness, as well as the financial toxicity. So thinking about things like missing work, unpaid leave, risk of debt, doctor bills starting to pile up. So treatment delays, especially for someone like Mary, can mean worse survival outcomes. She's got 2 young kids. We want to, what can we do to help support Mary? Where can we meet her needs? I think this also highlights that cancer doesn't just affect bodies, it infects entire lives. It's that kind of rippling effect of who all is going to be affected. So when we think about, Mary and how we can assist, is the same thing that we felt with Melvin. Can we get them connected to social work or navigation? Can they get them connected to gas vouchers? Maybe there's organizations that Mary can rely on to help with childcare. Mary may also be one that needs a little bit of respite care, a little bit of help being a primary caregiver and also a busy mom of 2. So thinking about that and really trying to, take a broad approach, like look at it from above, but also get kind of granular. And fortunate part is I think oncology care in general and how the health systems are set up, we really want to meet that mark, but sometimes we don't always. So I want to kind of talk about, what can we do and break it down into clinicians, health systems, and patients. So what can clinicians do? Leverage every interaction to screen, support, and connect. So screening for the SDOH regularly, routinely. Don't make it reactive. Talk about that to the patient. Even a quick 1 or 2 questions at the beginning of your visit is really, really important. Listen, validate, and advocate. So don't brush off non-medical concerns as kind of not your job. We're not asking you to solve it. We just want you to kind of refer and connect them to the resources and support, connecting them to navigation, to social work, to community health workers, where they can all kind of step in. And I think with patients, even just you listening to their concerns of kind of what's top and frame it like top of mind for them is so important. And it helps kind of build that trust, even acknowledging just the hardships that they are having, and having the empathetic response, but also doing something about it by connecting the patients to resources. What can health systems do? So beyond bedside, health systems play a huge role in either reinforcing or reducing inequities. So the goal for health systems is to kind of create an infrastructure that identifies, addresses, and reduces health inequalities. So integrating or building an SDOH infrastructure, so embedding screening workflows and integrating SDOH fields into the EMR system, investing in a workforce and community, hiring and training navigators and social workers and peer support roles is really, really critical and what we really need to focus on to help meet the needs of our patients. And then using data and analyzing data to drive change. So tracking disparities in outcomes, identifying gaps in either access or follow-up or treatment adherence is so crucial. Because if we can identify and kind of look at the broader picture of, what gap, where's the gap and how can we close that up or how can we improve that is really important. I think one of the other things I'll say is health systems must treat equity and equitable care as a clinical standard, not just a side project. I think we've seen a lot of that, different things come up within the social context, et cetera. And there's a lot of emphasis on it at one time, and then it kind of fades away. This has to be something that's a clinical standard that we're meeting the needs of our patients. And then I'll kind of close out here with what can patients do? So we want to empower patients with knowledge, with advocacy, and support seeking. So getting them to speak up about barriers, really creating that open conversation, open-ended questions, staying away from the yes, no. Are you concerned about housing? Yes, no. Rewording that a little bit so they feel more comfortable and it can explain a little bit more about what's going on in their lives. Seek help from internal support like navigation and social work. I feel like we are trying to do a better job about meeting patients from the very beginning, kind of that upstream approach before it gets down into, the trenches and things are kind of going awry. So early kind of seeking help from the internal support systems and groups and organizations that we have. And then building a support network and asking questions. So building a support network is really important because a lot of people don't understand until they're in the thick of it what all is entailed when you're going through cancer. It's not just the doctor's appointments. It's not just the treatment. It's everything in between. It's everything that is affecting and upending your life. So we want patients to have that to build that support network, whether that's with us as clinicians, as doctors, as nurses, as pharmacists, as navigators. We want them to feel kind of empowered and feel like they have other people that they can rely on, and other people they can lean on in their time of need. So, yep.
And here we have our final poll everywhere question before we turn it over in just a minute or two to our audience so that they may share their questions. Which area would you like to learn more about after today's presentation? A, screening tools for social determinants of health. B, community resource referrals. C, health equity advocacy. Or D, all of the above. And no right or wrong answer here.
I think this is really important because this presentation is, we only have an hour for this, and this is something that could be dived in for literally probably 40 hours, discussing different things. So it's really helpful for us to know kind of what other people are interested in learning about after today.
Absolutely. And the good news is for our audience that we have about 12 minutes where they can go ahead and ask these questions, and we'll address as many of those as time allows. So with that, I'm going to go ahead and advance this and then share that link in the chat there. So, and I'll go ahead and just make an adjustment on Poll Everywhere so that that's available so that they can go ahead and start sharing those questions. What should we know about your references, Danielle?
That this is probably just a small chunk of all of them. But the CDC is really fantastic. Another thing that I wanted to highlight, because I highlighted it with the graphics, is UNC Lineberger has a plethora of information where you can get those graphics of the different counties within the state and where they're at in their social index. You can kind of change the filters for that and what you're specifically looking for. And just knowing that there's still a whole lot of work to be done. I think with this presentation specifically, we're only kind of the tip of the iceberg of, what the barriers are and how we can help, not just as a clinician, but as a health system, and then how we can advocate and encourage our patients to seek the help that they need. So, yeah.
Great. And we already have our first, well, this is a comment, and this is when I didn't know much about the Medicare donut hole. So I was actually doing a little Googling on the side so I could ask you about that. And then I did see what this listener was commenting on, that apparently January 1st, that donut hole was abolished. Is there anything you can share with us about that?
I think more will come from that. There have been, as we all know, with the kind of what's going on in the world and especially politically in the United States,
Sure.
I think with a lot of cuts to kind of social funding and kind of concerns or significant cuts to programs like Medicare, Medicaid, Social Security, that sort of thing. I think it's just going to be kind of time will tell. Even though, if it has been abolished, a lot of our Medicare only don't have supplemental insurance plans. So then it's kind of like the coverage and the cost for additional medications or treatments, especially if they fall outside of like the kind of guidelines and what that looks like.
Okay. And we have another question coming in. What concrete resources can we provide patients to build their trust in the healthcare system? I have found that patients have difficulty trusting some resources we provide since they are coming from the healthcare provider they themselves are having concerns about. Thank you for a fantastic presentation.
Well, thank you. So concrete resources to provide for the patients. I feel like this is one of those kind of everybody's a little bit different. So some people want to see kind of the data. I know the kind of clinical trials team at UNC Lineberger has done a lot to kind of, especially in clinical trials and that sort of thing, when we're looking at that, trying to build trust with the patients of like, hey, this is what has previously been done. You know, we've got all the negative impact where they're trying to kind of change the rhetoric or kind of looking at that. I use the American Cancer Society, I think is really helpful for any patients that have questions about like their specific cancer. Also getting into the weeds with like different kind of cancer specific organizations. Peer support, I think is really great too. So having people that have kind of been through a cancer diagnosis or chronic illness that they can kind of talk to, because word of mouth is so important. Talking to your providers and really just having, as providers, building that rapport with your patients. Sitting down and just actively listening to what their concerns are without kind of thinking about only their diagnosis and only their treatment plan. That does a lot to kind of help build rapport and trust with the patient. And they're going to feel more comfortable talking to you about anything that comes up, whether that's, you know, their health related or their social needs.
All right. Thank you so much. Another question that just came in. Do you have a screening tool for social determinants of health that you like to use?
So for social determinants of health, UNC, the Med Center and the UNC EPIC system has already integrated a lot of these SDOH specific questions into the kind of EMR. So the primary ones that we ask about are kind of transportation, talking about like their housing situation. Are they living in a single family home? Are they living in an apartment with multiple people or multi-generational housing? Looking at things like, you know, can they read or understand what they're getting if they have printouts from their doctor or their pharmacist? Are they able to kind of address those? We know health literacy is still pretty poor in the state of North Carolina because literacy rates have climbed throughout the decades, but still kind of missing the mark when it comes directly to health literacy. So I don't necessarily have a screening tool for SDOH specifically that I use, but there are kind of questions built that a lot of our navigators use and our clinical nurses and sometimes even the front-facing staff, like the medical assistants when they're rooming patients, asking about like things like tobacco and kind of do you feel safe at home and that sort of thing too.
And here's a related question. There's a screening alert for SDOH that we do in clinic, but what is done with those responses to SDOH, especially when they indicate a need for support?
That's a great question. I will answer this to the best of my ability. So if the patient has been connected with like our central navigation team, then a lot of those SDOH questions are kind of addressed with them, and they're already looking at ways to connect the patient to resources specific to their SDOH or their social barriers. Now, as far as what happens when they do get into clinic, I think we try and do a really good job of kind of documenting, hey, this patient is really concerned about being able to get to their appointments, and relaying that and communicating that with the care teams, even preemptively, even before they come in for their appointment. And I do feel like, you know, we have a lot of help from our clinical nurse navigators that are working alongside the providers that are really helping to kind of address those concerns. And we're all working together, getting them connected to a social worker when they come in, getting them into our patient family resource center and getting them additional help in identifying some of those barriers.
Thank you. And here's a tough one. In identifying the components of SDOH, how could we help support the patient if there are limited or no resources available for their specific needs?
Yeah, this is a great question. Advocate, talk about it, bring it up to your leadership, bring it up to the organization and say, hey, like we're missing the mark here. what can we do? And maybe there can be things done within the health system and within the organization that helps draw greater support for patients with a specific need if there isn't really anything available or if it's limited in and of a sense.
Okay, thank you. And boy, I just want to say a huge shout out to all of the people listening today. Thank you for all of these great questions. Here's another. Do you have any advice on how to better educate someone on digital literacy to access records, appointments, etc.?
Yeah. So again, I think it takes all hands on deck. As clinicians working in an EMR or electronic health record, we know how to navigate the system. But what we need to do is kind of help our patients figure out how to do that. And a lot of times it's not the most time sensitive kind of thing where we're like, okay, we've got this appointment. But they're like, I don't know how to log into my chart. So getting them connected with, we have the Patient Family Resource Center where they can sit down and talk to somebody and kind of walk through the process of like logging into their MyChart, seeing when their appointments are, that sort of thing. I think it's kind of where I said, what can clinicians do? Think of like non-medical things as not your job. If a patient needs to access their records and it helps them keep up with their appointments, we kind of need to take on that ownership as well and sit down with our patients. Even if it takes a little bit of time, the help that you're giving that patient is crucial.
Yeah. Thank you. And not a question, but a shout out to social workers. I think we'll all be in agreement on this. They work so hard to help address many of these SDOH and appreciate all that they do. Wonderful resource to help.
Absolutely. Absolutely.
And anything, I'll follow up on that. Anything that you would say in terms of, as we look at a multidisciplinary approach to caring for the patient, about how for instance, you might in your role coordinate with a social worker and some of those specific strategies there?
Yeah, exactly. I think the biggest kind of takeaway is it's all of us together. We all have to work. The social workers, the nurses, the doctors, the pharmacists. It is a team effort, especially when you have oncology patients, like I said, that are doing a multidisciplinary approach. They've got surgery and radiation and medical oncology and with their chemotherapy or immunotherapy. It's all hands on deck. And I think the way that we help our patients the most is being able to collaborate and kind of integrate this within our daily workflows of being able to meet the patient where they're at.
Great. Thank you so much. And we're going to have you back because I have about 12 questions listed out, and I had them just in case, but I'm not going to have time to ask those. I do want to do, talking about shout outs, I want to shout out to Patty Morfeld. You'd mentioned LGBTQ plus patients, and we do have a few great lectures specifically addressing their needs with Patty Morfeld, and in some cases her presenting with another, as well as many other lectures. We have hundreds and hundreds in our learning portal and in our video library. So if there are particular topics that our audience wants to learn more about, that we encourage them to search our learning portal and our video library for those hundreds of different lectures that are available. We're going to go ahead and start to wrap up. We want to thank the funding that we received through the state of North Carolina through our University Cancer Research Fund. We want to thank the UNC Lineberger Comprehensive Cancer Center. We want to thank the team, Benny Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, and Kimberly Riddick for all the work that they do. Each of them touches each one of these lectures and makes them possible. We want to let you know that we always have more lectures coming up. We're busily planning for 2026, but lots to come in 2025 still. July 23rd, 2 weeks from now, we've got tackling immune-related adverse events, insights from UNC Immuno-Oncology Group, and that's with Dr. Ishizawa. And then on August 13th, we've got Do More Together, Engaging Community to Address Cancer Problems with our community COE group, our own Veronica Carlisle. So we're very excited about that on August 13th. And then our next advanced care provider lecture, and whoops, sorry, I have to change my view because it was cut off there at the bottom for me, but CAR-T in North Carolina with Dr. Grover. That's August 27th, all of those at noon. So we hope that that you'll be able to join us for those, or let somebody know about those if that's something that you think would be of interest to others. And then we've got our self-paced online courses, always more of those, dozens that anyone can take at any time. They include various types of continuing education credit and no cost to anyone who's taking those, regardless of where you are. And we encourage you to reach out with questions, comments, 919-445-1000 or unclcn@unc.edu. We mentioned learn.unclcn.org as the learning portal, and then our main site, unclcn.org. Danielle, thank you so much. This has been great. We really appreciate having you on today. I think we learned a lot.
Thank you so much, Tim. Thank you, everyone, for joining.
Okay, take care, everyone. Have a great afternoon.